Hello, everyone, and welcome again. My name is Injaz, a communication specialist at Center for Epidemiological Modelling and Analysis, CEMA, and I'm delighted to be your moderator for today's webinar. Thank you all for joining us. Today, we'll explore how data and modeling can drive progress toward global disease elimination, learning from practical applications and case studies that highlight their real-world impact. This session is part of the Injaz Fellowship webinar series, jointly hosted by CEMA and Global Institute for Disease Elimination, GLIDE Injaz Fellowship. Before we dive into today's agenda, I would like to briefly introduce our speakers, who are Professor Thombe Mwangi, CEMA co-founder, and Ngozi Erondu, GLIDE Technical Director, who will give their opening remarks later on. And our main speakers today are Dr. Peter Masharia, a geospatial health specialist at Institute of Tropical Medicine, Antwerp, who will share a malaria-focused case study using geostatistical methods. Dr. Motono Nyamai, a senior research fellow at CEMA, will also present a case study on applying mathematical modeling on neglected tropical diseases. Later, we'll also have an open Q&A discussion and closing remarks. But before we begin, I'd like to invite Isatu Diware, technical specialist at GLIDE, to briefly tell us more about Injaz Fellowship. Welcome, Isatu.
Thank you, Annie, and welcome everyone again to this joint webinar between GLIDE, Injaz Fellowship, and CEMA. So as Annie mentioned, my name is Isatu Diware, and I'm a technical specialist at GLIDE, and I'm also the lead of the Injaz Fellowship. So I'm really glad that we were able to bring our programs and organization for this shared moment of learning. So I would like just to give you a bit of background on the Injaz Fellowship that was launched last year to support mid-career professionals in deepening their knowledge, sharpening their leadership skills, and expanding their influence in global health and disease elimination. And the name Injaz means achievement in Arabic, and that's exactly what the program is about. And the fellowship supports GLIDE missions to build a strong skilled professionals to help advance global thinking and accelerate progress towards disease elimination. So with that, I will now hand over to Hani to continue the moderation. Thank you, Hani.
Thank you, Isatu. To get us Professor Thombe.
Oh, sorry, I lost you for a minute there.
Sorry.
You can hear me?
Yes, we can hear you loud and clear.
Well, thank you very much, Annie and Diawara, for asking us to give these initial comments. Actually, I thought I should just share maybe a slide or two in preparation for this talk. Let me know if you can see my slides.
Yes, we can.
Is it in full presentation mode?
It was in full and then something happened.
And now?
Yes.
Okay, great. So today we are discussing about entity elimination, and I thought I should just do 2 or 3 slides about entity elimination science. First of all, I think as you're all aware, we have done a lot, I think, as a continent and obviously other parts of the world regarding disease elimination. So from this view here, we have got at least many countries that have managed to eliminate at least 1 or 2 NTDs over time. like Kenya, very recently this year actually was declared free of human trypanosomiasis. Actually, this very and this kind of progress, I think, is really important. We know that for many of our neglected tropical diseases, we have got some that are in the control phase, others are in the elimination phase. And in the world, at least, you have managed to eradicate 2 diseases, basically smallpox and rinderpest in cattle. But what I wanted to do today was invite us to think of the elimination as a continuum. So you have got a control phase, a pre-elimination phase, an elimination phase, and a post-elimination phase. And in the control phase, you often have a lot of cases happening. So there are the cases that you can see, and there are cases that you don't see. So it's like a tip of the iceberg of what you see. And in this control phase, you have got, in epidemiological terms, you have the reproductive number, which is the number of secondary cases that you can get from one primary case being above 1. And our aim is really to take that number to below 1, at which point you really see very few cases, except maybe for localized outbreaks or that may be related to outbreaks, to importations. And this is the idea that we want to drive many of our entities towards this particular phase. And when you have gotten to elimination phase, then you sort of have to have some certain activities that help you keep you free of the disease within the location. And so if you think about like the work of modeling, which could be either geostatistical or even dynamic modeling, the idea really is for each of these phases, the control phase up to the post-elimination phase, that there are things that you can do and that can be informed very well by this kind of modeling techniques that we'll be discussing today. So if you think about like the control phase, the pre-elimination phase, the critical questions you're asking at that point is, how do we target and optimize interventions so as you can drive the number of cases that you see within a population to 0, or to numbers that are not detectable. And even when you have attained elimination, the additional questions that you have to really deal with is, what kind of surveillance must you put in place so as in case there's any new case that comes in, that you're able to catch it early enough and that you can have control measures that make sure that you remain within the elimination phase. And this risk of resurgence is a sort of a difficult question to answer, minus the use of models. And so today, I think what you're trying to do with these 2 excellent talks from Macharia and Motono is to say what might be the work or the role of geostatistical and dynamic modeling tools, which can be incredibly useful in helping make decisions around this continuum of control and elimination. And so I am looking forward to hearing and listening to these 2 very excellent talks, and I hope that we all enjoy and we have at least an opportunity to ask questions at the end. So thank you very much. I hand over back to you, Annie.
Thank you, Professor Thombe, for setting the stage. And we'll now hear from Dr. Ngozi. Dr. Ngozi, go ahead, please.
Thank you, Annie. It's really great to be here. Thank you to Professor Thombe. Thank you, Aissatou Diawara, and our colleagues at CEMA. It's a pleasure to welcome you all to this webinar on behalf of the Global Institute for Disease Elimination, also called GLIDE. We're really excited to co-host this important discussion, and we thank everybody for taking the time out of their day. So as I think Professor Thombe elegantly said, modeling is a powerful force in public health, and often we've seen its importance most visibly during pandemics and outbreaks, where people can see that modeling really helps us to forecast transmission and identify where resources are most needed. They also help to guide the emergency response when it comes to uncertainty. But as we know, its value extends far beyond just a moment of crisis. Often modeling also works very quietly in the background, informing where we position interventions and how we sustain elimination gains. And it helps us to make difficult choices, especially when resources are stretched thin. At GLIDE, we see modeling as a critical investment area. So for example, we have one project that we've been working together with WHO EMRO, that's the Eastern Mediterranean Regional Office. And we've been supporting them to use ecological niche modeling to look into where you can prevent malaria reintroduction in this region, which has eliminated malaria in most countries. And some of the factors that are included in that are climate change, vector migration, human mobility, and it's really about anticipating where the risk of resurgence are highest. A lot of what Professor Tumbi just explained. And it's important to do this so you can help countries protect their hard-won progress. And it's an example of how data can guide smarter and more strategic decision-making for disease elimination. And actually, that project with WHO EMRO, I'm really pleased to say that there are several colleagues in Kenya Medical Research Institute that are supporting that work as well, also led by Professor Bob Snow with KEMRI and Oxford. So we know that modeling is important, but I want to just say what everyone else knows is that modeling is just one tool among many, and it complements rather than replaces local knowledge, surveillance data, and the experience of program managers on the ground. Models do not make the decisions, the people do. So I think this webinar today is really important so that we can see how modelers present the information and then what those experts actually use, how they discuss the information that is provided to help guide their decisions. And of course, I want to take a moment to recognize our Injaz Fellows. Dr. Diawara just shared what our Injaz Fellowship is about. But this is, as Annie said at the beginning, this is part of our Injaz webinar series. And the Injaz Fellowship is really one of our flagship programs, and it's designed to equip emerging leaders in disease elimination with both technical and strategic skills. So among other things, our fellows are benefiting from webinars like this because they're learning what analytical and decision support tools are available to them to strengthen their leadership and to make better data-informed choices in the field. And I know that this is also what CEMA does, is ensure that, students, whether it's a University of Nairobi or practitioners like you and myself are informed about, how modeling can really help us, how it can be a tool in our toolbox when we're making important decisions for public health. So I look forward to the conversation. I am in gratitude to Dr. Nyamai and Dr. Macharia, who I had the pleasure of working with in a previous life. Thanks to both of you in advance for sharing your expertise and for all that you do to contribute to this important conversation. And I look forward to the discussion ahead and to hear how modeling and the insights provided can help each one of you on the webinar move from data to insight and from insight to action in the work that you do. Thank you.
Thank you, Dr. Ngozi, for those remarks about how modeling and data underpin evidence-based strategies in global health. And now we'll move to our next session on case studies, and we'll begin with applying geostatistical methods in global health malaria-focused case study presentation by Dr. Macharia. Dr. Macharia, please go ahead. ICT, Catherine, could you please unmute Peter Macharia?
Perfect. Now,
Awesome.
Yeah. Thank you for the introduction. I'm going to share my screen. Perfect. I hope you can see my screen in presentation mode.
Yes.
Thanks, Annie, Dombi, and Ngozi for the perfect introduction. So here I'm going to share briefly in the next 20 minutes how we've been using geostatistical model in global health. And for the case of today, I'm just going to speak about malaria. But as we know, geostatistical methods can be used in a lot of applications in global health. But here is just malaria for today. And this is just a brief outline of what I'm going to speak about, why we do disease mapping, then deep dive a little bit in model-based geostatistics, then give a case study, and I'll have some few concluding remarks. And I want to begin here, like, why does it matter that we need to talk about malaria mapping, malaria modeling? And those in the field of malaria have already seen the World Malaria Report 2024. And if you see this map here, it's telling you that we have a lot of cases, and Sub-Saharan Africa, as we know, is left behind in so many things. And here is still the case. For example, in 2023, we had almost all the cases that were recorded, that is 94%, were in Sub-Saharan Africa. And almost all deaths that occurred due to malaria were also in this region. And more specifically, about 76% of all these deaths are in children under 5. So it matters to really think about this, given all these statistics. And these are not just numbers. Some child somewhere is dying out of this disease. So I like to share here why do the mapping? Why is it important, or why should we bother? And I think the first thing is to try and understand the prevalence at very high spatial resolution and temporal resolution, so that we can actually really see where the hotspots are, and then we can focus very targeted interventions to the areas that we need them. It could be like in pre-elimination phase, could be in control phase, but in all these phases, mapping is very key. And then sometimes you might want to know what is, for example, the role of covariates, or what were the role of the different interventions. So for example, say since 2000, what was the role of bed nets or IRS in terms of malaria control and elimination? So if you think in all this, you might have a different case study wanting to know one of these aspects, or you can have a study that wants to look at all these combined in a single study. And we are going to see some of these in some case studies that we have applied in the past. But maybe let's take a step back and think if these maps are actually useful for decision makers. There was some work that was done a few years ago here, and people in national malaria control programs were asked if they use maps and what they use them for. And they said most of the time they tend to use some model estimates or data from our routine systems or data from the DHS. And they use a lot these for targeting of interventions, or just justifying for why they need some finances, or they want some for some planning, that kind of thing. But most here 3 countries were asked, and it's only Kenya that time they say that they were using some model estimates. And some of the issues that were coming in the uses of this map is really understanding what is happening behind the data, so that they can own the process. And I like this piece that was written by Noor, about 10 key points. And one of the points he said is that country ownership is not yours to ensure. You certainly cannot confer it. So even as we speak about all these maps and modeling, we need also to think whether these maps are being applied, how useful they are, and how we can actually go from just modeling to making better use of the products that have been produced. And if we go to the beginning, what data sets then do we need to do a modeling, and in this case for malaria? In most of the country, we have data from our routine health information system. So this could be like, for example, DHIS2. A number of countries tend to go to these data, but more commonly is the demographic and health surveys. Here, for example, you can see Ghana in their most recent DHS, making a map of malaria. Then we have malaria indicator surveys. This is very recent from Kenya. And then you have school surveys. So in a country, one of these are likely to be used to inform decisions, or a combination of these. And which one they go to, if you refer to the previous slide that I had, they'll have a number of reasons why they choose to use one data set and not the other. And among those 4 data sets, those that are from cross-sectional surveys are more commonly used. And if you see from this graph here, these are surveys that have been done by the DHS program over time. So you can see from like 1984, when the first survey was done, almost up to 2025, a lot of surveys have been done over time. And you can see in Sub-Saharan Africa, majority of them have been done. And a lot of countries rely on these cross-sectional data sets for their mapping and modeling when it comes to malaria prevalence. But also good to mention that we know what happens to this program and its funding. So here there is also a big debate to talk about the data that are being used to inform decisions in countries. So going back to the most common data set that is used, and I'm again here picking Kenya, and this is the most recent malaria indicator survey. This is what was in the report. And they stratified the country into several regions, and then they presented the prevalence in the different regions. So you can see in the lake endemic, they had a 19%. Then you have low risk, 1%, seasonal, 2%, coast endemic, 5%, and highland epidemic prone had 1%. But is this enough in itself? Because this is already provided in the report. There is no modeling that was done here. Can we just stop here and say this is enough to make decision within the country? And this is why I want to make a case for why we might need geostatistical model to move from this map to a more informed map. So here I'm going to give some reasons why I think model-based geostatistics is needed or would be useful for decision makers to move from the current map that you are seeing that is commonly presented in reports. And this is not only the case for malaria, but it could be for any other health outcome. If presented in this, it has little use compared to applying some MBG techniques. And one of the things that makes us use model-based statistics could be the result of sampling error and uncertainty that is involved in the data that was collected. Then we want to be able to smooth out all that noise in the data, especially in areas where we had not really sampled, and end up getting some stable estimates. Then, as I said earlier, we need to get like very fine scale estimates for targeted interventions. So we can know within this county, which is the village, which is the locality that has problem and really target that specific issue. Then more importantly, you might have data sets from multiple sources, as I had shown earlier. You might have routine data, data from DHS, data from MIS, data from school surveys, and model-based statistics will allow you to combine all these data sets together and get a more better, robust estimate. And finally, I think it's also important to be able to simulate what-if scenarios. So what if we were to increase, say, bednet coverage up to 90%? What if IRS was to be introduced in this area? What would happen to malaria prevalence? And I like that geospatial science can do a lot. This is a framework that was presented a few years back. So here you have the environment where all the transmission is happening. You have all your interventions. You have infrastructure and residences. Then on the other side, you have the disease and the vector. You can bring all these parts together in one geospatial framework, and you can do different things. You can do simple or fundamental spatial analysis, or you can apply some spatial statistical analysis for different things. So you have like maps of interventions, identify clusters, you can do spatial prediction. And for today, we are talking more about the use of spatial statistical analysis. So just giving a very brief overview, then what are these geostatistical models that I keep mentioning? And it's just a branch of statistics that aims to come up with a continuous surface from your sampled data. So you've collected this data from different points, and then you want to end up with a continuous surface. And the main principle that is applied here is like extending the statistical model by introducing a geospatial component based on the first law of geography, that everything else in space is related, but we know things that are close together are more related than those that are far apart. And the very basic structure of this model is to say, if we want to understand the variation in our outcome, which is the malaria prevalence here, this is due to the covariates Then you have two random effects, one that is spatially correlated and one that is not. So the variation in our outcome here is explained by two things, the covariates or the predictors, then we have some random effects which are split into two parts. So assume you've gone to the community, you've gone to households located in a certain geographic area, then you've gone, for example, maybe to children and taken a sample of the blood and you've tested whether they have a malaria parasite in their blood. Then out of those, you have a number that have returned a positive outcome. So you'd be able to make such a map. These locations could be the households. Then the proportions that returned a positive outcome in each one of those locations. And this location could be a combination of households. So this is a cluster. It could be 20%, 0%, 30%. So this is the data that you are able to present after your field work. And for example, this is East Africa, and this is a combination of many data sets. Then comes the model that we want to use. So this is what I said earlier, but represented in an equation form. So we want to model our malaria prevalence, that is our outcome. Then we have covariates that have been observed, recorded, and we know they are associated with malaria prevalence. Then we know that it is not only covariates that might explain what is happening in terms of variation of the malaria prevalence. We have a spatial component, and then we have the noise that remains. So if you think of these last two parts, which here is S and Z, this is all the variation that is not explained by your covariates. That's what remains. So you have your covariates, then whatever is not explained is S and Z, and you can be able to model your outcome. And this is just very brief. A lot of assumptions are in there. And I'm just putting up this slide because I think these are very important resources for somebody wanting to dig deeper. For example, the first book by Emanuele, which is Geostatistics for Global Public Health. So it's a very suited book. And also the other two here, one by Paula and other by the three others here. I want to show an application of that model to malaria data in East Africa. And here, this is a paper that was led by Alegana and a group of people from Kemri Wellcome Trust. This is the data that I shown earlier, that we want to be able to interpolate in space and see what is happening in all the unsampled places, and then use that data to make some informed decisions. As I said earlier, we need covariates. So the malaria transmission is not happening in a vacuum. A lot of things are going on. On one side, we have the environment, then we have the household or the compound within a household within a compound. So for example, you have like ponds somewhere where it can encourage some larval breeding. Then within the community, there are some outdoor activities happening, or whether you are protecting yourself, the kind of household you are living in. So there is a lot of things that are surrounding malaria transmission, and we would want to be able to capture this through covariates. So you can imagine this landscape here, including the weather and climate, being captured in terms of geospatial data sets. And this can be many, they can be a lot. So like temperature, demographic factors, humidity, and a lot of work has already been done in this space, thinking about what covariates should be used when we are modeling malaria prevalence. Here, work by Weiss, there is work by Julius, some work with Emmanuel here, just looking which covariates should be used, how should they be used, what is their role? Is it to explain? Is it to predict? You can have a look at these papers to understand this space more. But at the end of the day, we want to come up with a set of few parsimonious covariates that are able to explain our outcome. And these are the covariates that were tested in the East Africa case study. So on one side, you have your data here. Then you have your geostatistical model that I showed earlier, which also includes a set of parsimonious covariates. You end up with this map from this household or clusters of households, you end up with a continuous map that now speaks a lot, with blues showing low prevalence and the orange and the reds is showing very high prevalence. You can already start to see some hotspots and thinking which area should I think of taking more interventions, or which areas should I think of going to pre-elimination phase. And if you are to get to a decision maker who says, okay, I don't understand your continuous map, I want my map in the areas that are used to make decisions. For example, these might be counties or sub-counties, districts or councils in Uganda. And if this is what they understand better, you can be able to share this kind of map. And this is not the only aggregation unit. You can even go lower, but the lower you go in terms of your administrative unit, the more uncertainty you are likely to get. And here I wanted to touch on areas that say are very low, and these are less than 1%, and this is the light yellow color. And here, if you do like blanket application of interventions, you might be wasting your resources. So you might want it to be very focused. So for example, it might be in this swath that is yellow to go to pre-elimination phase, but that has implications. So we need additional resources for early case detection. We need to be able to do very fine resolution mapping, even lower than 1 kilometer spatial resolution. We need a very robust HMIS. So whatever decision you make will have implication. But the areas that are very dark here, brown, we might think, okay, this is the areas that we need to take our vaccines. These are the areas that we need to try new interventions. It's suggesting that whatever we are doing is not enough. So this map, it is showing the whole continuum, like from the very high to the areas that you need to be doing some things leading to elimination. I want to a little bit focus on the areas of low transmissions. In the map that I showed earlier, you are able to go a step further, not just show the map that was in the previous slide, but how sure are we that the areas were less than 1% are actually less than 1%. So non-exceedance probability, the probability that this area does not exceed 1% in terms of prevalence. And you can do different thresholds. So for example, this is less than 1% at 90%. So we are really very sure that these areas are less than 1%, and we can advise to go to the next phase of disease control. On the other side, you can say which areas are more than 30%, so that we change whatever we've been doing. So specifically for areas that are less than 1%, doing data collection, as I showed earlier, might not be the best way going forward. So the sampling strategies that we are using might not be appropriate, given that disease is very low. You might need to sample a lot to be able to get a meaningful prediction. So that snapshot of a survey like DHS or MIS now does not become that suitable. And we know a little bit about RDTs that are used to detect whether you have an infection, and it could underestimate. So we think of routine data, because this data is available throughout the year and we can see whatever is happening across different seasons. But then there are some questions. How reliable is this data? If you've used data from the routine systems before, you'd understand that there is a lot of missingness. You get percentages that are over 100%. So a lot of things to deal with here. And remember, these will only record those people who went to seek care. It is missing everybody who was sick but did not go to the facility. And also the capacity of the health facility to detect whether you have a parasite in your blood is also another issue. So this means when we are moving from control, where we are doing periodic surveys like DHS, MIS, it's okay to do that at provincial, district, county level, that's okay. But as we head to elimination, we need to be able to do like real-time individual level data collection. And here, this is my second last slide. This is an example that Alegana showed how, when we are heading to pre-elimination, how still we can be able to use geospatial or geostatistical techniques to know where we are going to really focus our energy on. On this panel A, you have different households, and those that are red say they have some kind of infection. H is a hospital, and you have a cross with a dispensary. And say here you can already start seeing there is a hotspot coming up, and you can see there is some water ponds here. Here, this is the probability that you will seek care after you get fever. So distance here plays a very big role. You can see those that are close to a facility are likely to seek care. Those that are far away are unlikely, controlling further things like wealth. Then here you can think of how the landscape looks like. Then you have data from your facilities, and you can be able to make this map here, and you show areas where like disease is concentrated, and then you can focus really your intervention and your focus in this area. So this is a different set of analysis that is not now using survey data, but is using routine data, using the probability whether you are going to seek for care or not. So we are accounting for those people who did not seek care, using a lot of environmental covariates data from the routine system to be able to make this kind of prediction. And to conclude, I'm thinking in terms of low middle income countries, sub-Saharan Africa, where we are in terms of this kind of skills or this kind of work. Number one is data. It's our routine data is not very good. And now we see like the funding landscape is not very good given what happened with the DHS program. If you think about model-based statistics skills across sub-Saharan Africa, you have just a few centers of excellence that you can think across, maybe in Tanzania, in Kenya, and a few other countries that are able to do this kind of modeling. Then think of the infrastructure that is needed. If you are doing this kind of modeling for the entire of sub-Saharan Africa, you need a lot of resources, which is not well distributed across sub-Saharan Africa. And now this is very key, coming to what I said when I was beginning. How do we communicate these? Are decision makers going to accept these? Are they going to be part of this process? And finally, beyond just a program coming for 3 months or 3 years, then after that, it goes. So you support the country for a few years. Then how are you going to make these programs sustainable so that it becomes part of our routine decision making? And I think that's my last slide. I think that's what I could be able to share given the time limitations. Back to you, Annie.
Thank you so much, Dr. Macharia, for sharing that insightful presentation and for highlighting the power of data and spatial analysis in advancing disease, and in this case, malaria control. Dear participants, please use the chat to post your questions. Also, you can keep them a dedicated Q&A session. And now into our second presentation. We're now moving to tropical diseases, and this presentation is by Dr. Motono Nyamai of CEMA. Welcome, Motono.
Good afternoon. Are you able to see my slides?
Yes, yes.
Yes. Which view are you able to see?
Yeah, we can see like the full screen view.
Okay, great. Thanks for that, and thanks, Macharia, for the nice presentation. I'll now take you through epidemiological modeling, and the example I'll use is schistosomiasis, which is one of the neglected tropical diseases. I work at the Center for Epidemiological Modelling and Analysis, which is at the University of Nairobi. And I also have affiliation with the Paul G. Allen School of Global Health, which is at the Washington State University. So to start us off with some history, I'd like to move all the way to 1851 when there was a surgeon, Theodore Bilhaz, who found an adult male and female worms during an autopsy during a patient in Egypt. And during this time, he didn't know which worm he was dealing with. So he initially named the worm Distoma haematobium, and Distoma is just from the family of worms which are suckers. But then later, it was named to be Schistosoma haematobium, and it picks the name Schistosoma from the split body, which you can see in the image on the screen, and where schisto just means split, and then soma means body. And that's the name that it's been commonly used year after year, which is schistosomiasis. And also some people name it Bilharzia, which was named after Theodore Bilhaz. And from 1851, now moving all the way to 2025, and you can see that nearly 200 years after schistosomiasis was discovered, we still see cases of schistosomiasis in the newspaper. And for this, I just did a search of any stories that have been done on schistosomiasis over the last 3 years. And what you can see on the screen are just excerpts of newspaper articles from both the Nation newspaper and Standard newspaper, which are two leading newspapers in the country. And you can still see that schistosomiasis is a problem. So the question is that how come nearly 200 years, we're still seeing the cases of schistosomiasis year after year and even with regular treatment? And today, my presentation will just spend time to look at how modeling can influence the treatment decisions. So that to look at where to target, to look at, are we targeting the wrong places? Are we treating the frequency suboptimal than what's required? And with this, we'll be able to provide evidence that generates towards showing how we can actually break transmission. I'll start you off with the life cycle of the disease. And this, we can start from where people uptake the infectious larva of the worm, which is called Saccharia, from the environment, either through when they step into water that's contaminated with this Saccharia, and they penetrate through the skin, and then grow into the human hosts, become worms. And from there, they start they copulate and produce eggs. And when the eggs are shed from the infected human into the environment through poor sanitation, then they end up being miracidia, which are taken up by the snail, freshwater snail, which acts as an intermediate host. And after a while now, it releases the Saccharia, which is the infective larva, into the environment, and the cycle continues. The interventions that are seen to stop the transmission. So one is through the mass drug administration, which kills the adult worms, but it does not provide any immunity or kill the juvenile worms. And also there's the improved water and sanitation and hygiene, which tries to ensure that the eggs are not shed into the environment, but also people don't take up the worms from the environment. And there's also snail control and behavior change. And even with these 4 interventions, the main intervention that is currently used is the mass drug administration with praziquantel. There has been different species that have been seen for schistosoma, and we can see that there's the 2, that's the Schistosoma mansoni and haematobium, which are found in the African continent, but also we've seen the Japonicum, which is found in the Asian continent and Mekongi. And for this presentation, I'll focus on the 2 which are the public health concern in the Africa continent, that's mansoni and haematobium. And the mansoni is also called intestinal schistosomiasis, and the haematobium is related with the urinary tract. In 2016, the disease accounted for 1.9 million disability-adjusted life years. And in 2023, we saw that 254 million people globally resided in areas that are endemic for the disease, and 91% of them were living in the continent. Something interesting about the infection of both the haematobium and also the mansoni is that the intensity is mostly seen in the 5 to 14 age group, where on the x-axis, it shows the age group in years, and the y-axis shows either the mean intensity, that's egg per milliliter of urine in the haematobium, and then egg per egg per gram of the stool sample in the Mansonai. And we can see that the intensity peaks between the 5 to 14 years. And similarly, where the dashed line you can see is around even after mass drug administration, they still are the ones who pick up with the infection. And before 2022, the treatment interventions were really focused on this age group, that's 5 to 14 years. And recently, that's in 2022, the guidelines were improved, and now they targeted population 2 years and above, because they were also seen, as much as they don't contribute much compared to the 5 to 14 years, if you're heading towards elimination of as a public health problem, then you also need to focus on the other age groups which act as reservoir for the disease. And so the guidelines were improved to show that, one, you first needed to do baseline prevalence of the area. That means you collect either stool or urine sample and test for the check for the eggs in the sample for the population. And with this, you would use the school-age children to ascertain the prevalence of the population. And once you're certain that the prevalence is either above 10%, then you treat. But the treatment decisions were broken into three based on the prevalence, where if it's less than 10%, then the decision would be you test and then you treat the people who have now the infection. And then when it moves to above 10% and the prevalence is below 50%, then you treat once a year to the population 2 years and above, with the hope of targeting 75% of the population. Then in the above 50% prevalence, then the recommendation was treating twice a year. And the plan is that you should treat, and in every 3 to 5 years, you need to do a prevalence of evaluation to check whether has the prevalence gone down or has it maintained, and there are treatment decisions that should be done based on that. And then the plan is to be able to move to elimination as a public health problem by 2030, which is defined as less than 1% heavy intensity threshold among the school-age children. And the heavy intensity threshold here is defined by 50 eggs per 10 ml of urine for hematobium, and then 400 eggs per gram of stool in the schistosoma mansoni infections. In the same breath, Kenya also has its own treatment guidelines, and where Kenya is focusing on breaking the transmission strategy. And this is seen from the 2019, where they had the breaking transmission strategy. And this is now embedded in the Kenya NTD roadmap 2023 to 2027. And the plan is that to be able to reach less than 2% prevalent threshold among the school-age children. So for Kenya, currently we treat 5 years and above population, and still targeting 75% of the population. And the treatment here is where you do once a year treatment until the prevalence is below 2%, where now we do not have any mass drug administration. Recently, that's 2019, and also last year, moving to this year, Kenya did its comprehensive prevalence of the population. And this was based on the point where for a long time, we've been focusing on treatment in the Western region and the coastal region. But the plan was now to look at the prevalence in the whole country. And with this, where I've shaded is to show the Western region and the coastal, which has been focused on treatment. But we were able to also do mapping for the whole country. And you can see that there's heterogeneity, where there are some areas where we have no prevalence, but some areas we still have more than 50% prevalence. With the current treatment strategy that we use in Kenya, we do once a year mass drug administration to population 5 years and above, and we exclude pregnant women in the treatment. So the questions we got from the Ministry of Health is to look at, one, what would be effective treatment strategy to achieve the Kenya target of breaking transmission, which, to just remind you, is less than 2% prevalence in the school-age children. And two, what would be the meeting the WHO target of elimination as a public health problem, which is less than 1% heavy intensity in the school-age children. So the approach we took was in two. So first, we looked at what if we would achieve the target by just treating as we normally do. That means We treat population 5 years and above once a year, achieving 75% coverage, and also including population that are never treated at 15%. And I'll shortly talk about what we mean by population never treated. But basically, this is a population that with different continuous round of treatment, they continuously don't get any treatment. Then the second question was, what would be an optimized treatment scenario where we would target the right population based on the prevalence and ensure that in the higher prevalence settings, we introduce twice a year treatment while also reducing the population that's never treated. So we started with 15%, moved to 5%, and then 0%. And particularly on the treatment focusing on the school-age children was based on our previous work where we showed in the low prevalence setting, that's less than 10%, there would not be any gains in terms of years if you treated the whole population or just focused on the school-age children. And then from this, we then move to the next point of looking at what is the economic evaluation of the different scenarios above. So the costs we focused on were the economic costs, and this meant that we also costed things that were given in kind, for example, like the drugs which are currently being donated, and any other service that's given in kind, and costing all that, and looking at the cost from the government perspective. So for this piece of work, we did not look at the treatment from the patient perspective. To just summarize the model world, I always like using this graphic where we know that the real world, there's a lot of complexity. Like, for example, how I've talked about with schistosomiasis, we know that there's a behavior change control. There's the behavior change. There's the aspect of also the water and sanitation and all that complexity that comes with the real world. But how we do with the modeling, we abstract the main things, the key things, to the model world, where we use now equations or distributions to be able to see how we can simulate the infection in the population, and then now implement that into a model. And once we have the output from the model, we interpret it back to the real world to see, does it make sense from what is seen in the real world compared from the model? And I use the example of Nelson Mandela's image, where in the real world, we have all this complexity and also granularity, where we are able to see the color of his skin, the color of his hair, the color of his tie, and so on and so forth. But in the model world, we only abstract the key things where we still maintain that it's the same disease we're focusing on, but removing some of those granularity. So the model that we used here was an agent-based model, which just simulates every individual with the heterogeneity that comes with it, where we know that some individuals are more predisposed to taking up the infection compared to others. And one of the key things that I'd like to focus on the model is on the aggregation parameter. And parasite aggregation is just basically the non-uniform distribution of parasites among hosts, where it's been seen that a few individuals have more parasites than others, while most have a few to no worms. However, if you look at, I hope you can see my cursor, but I'm looking at the graph on the left, where on the y-axis we have the aggregation, and on the x-axis we have prevalence, and where if you move above the prevalence, so you have a higher prevalence, then the parasite aggregation becomes low. That means we move from a non-uniform distribution more towards a uniform distribution. And here we find now more people having more parasites. And this now moves to a higher K. However, when we move lower into the prevalence, then we see now a higher parasite aggregation, where many people have few to no worms, but a few people have a lot of worms. And now this is the heterogeneity that we have in the model, and where other things that play an important role in the model is, for example, where we model out the worms into the human host, where we have a density dependence fecundity, where The fecundity is just the number of worms that can be produced by the number of eggs that can be produced by a female worm, so that we also control overcrowding, where if you have so many worms in the body, then it means then due to overcrowding, every worm will produce less eggs. But then if we move to the point where you have less worms, then the production becomes more. And then also this is dependent on the number of female worms in the body, because you need a female-male pair to be able to produce the eggs. And then the eggs also are now shed from the human to the environment. And in the environment bit, we do not explicitly model this. And this is because there's a really short time period from the point where the miracidia are shed into the environment and then being taken up by the human. So we just start with a set predefined number of cercaria in the environment, and then the cycle continues. We have some model assumptions that we have. So one I've mentioned, where the miracidia and cercaria are not included because of their short lifespan. And then the other one is on the treatment, it reduces the worm burden at a one-time event. So there's no immunity that's created, such that if individual was treated today and then maybe the day after tomorrow, they then went to a freshwater body that has cercaria, then they're able to take up the cercaria, and then the cycle continues. I'll dwell a bit more on the model assumptions that we had. So one is where some individuals are more predisposed to uptaking the cercaria. And one of this where I mentioned is where children 5 to 14 years based on their age, but also based on their livelihood, where people, for example, who do fishing, like the fishermen, are more predisposed to taking up more because of their livelihood compared to others who are not interacting with water bodies a lot. Then the second, as I earlier mentioned, the rate of exposure is highest in the children 5 to 14 years, who in other literature, they refer to them as school-age children. And here I just use the acronym SAC. Then the third one is the individual's predisposition at their end and access to intervention are fixed for the remainder of their life in the population. So if we say that geographical access to the intervention is 100%, then that is set. However, if we only have a small proportion of people who have access, let's say 50%, and if someone falls out of the 50%, then the access to intervention is fixed for the remainder of the period. Then I mentioned on the MDA treatment with no immunity. But then the next bit I want to focus on is the economic assessment that we did in this work, is where we used the routine programmatic data to determine the cost of delivering drugs to an individual and calculated this for the population. Mentioning now back to the population never treated, I'd like to use this graphic that you can see on the screen, where if I start with the first column, if we say that we treat 75% of the population with everyone adhering to treatment, then we randomly pick people who will be treated. But that means if you are randomly picked to be treated in this round, you will not be treated in the next round. But after 2 to 3 rounds, it means everyone has received treatment at least once. Then now in the last bit is where I want to focus on, which is on the systematic, the last column, where if someone is not receiving treatment, then the treatment will only focus on the people who are in the blue shaded area. So if you fall out of the blue shaded area, that means during the whole period, even when others are receiving treatment, you'll constantly be excluded in the simulations that we're doing. So based on that, because Kenya has both the schistosoma mansoni and also haematobium, we then did simulations for both, because some of the parameters are different. And with this, we saw that if we did the elimination as a public health problem, focusing on schistosoma mansoni, where we looked at low prevalence all the way to high prevalence, we saw that if we continued with the current blanket treatment that we're using, where everyone just receives treatment once a year with 15% never treated, then we saw that in the low prevalence settings, we're able to achieve elimination where it's in the dashed line. However, when we move into the higher prevalence threshold, where you see the red line, we'd see that it would take us a long time, almost 16 years, to be able to reach that target. And in hematobium, it take us longer. So combining the two, then it meant that it would take more than 20 years to be able to reach the elimination as a public health problem. To be able to accelerate this, we saw that in the higher prevalence settings, if we focused on having the reducing the proportion of the population never treated to 5% or less, and including twice a year treatment, then this would accelerate the achievement of the target, reach this in less than 20 years. And I'll show this later with the precise numbers, years, with now the costs. Then now, when we move to the hematobium, we saw that even with the blanket treatments that we are having in Kenya, we would only achieve that in the low prevalence and the moderate prevalence in the lower band. But then if we move to the high prevalence of 50% and above, it showed that with the red dashed line, it will take us more than 20 years. And if we wanted to accelerate this, achieve this within 12 years, then it meant that we have twice a year treatment in the higher prevalence and reduce the proportion never treated. Now coming to the economic cost, where two things stood out. So one, for the elimination as a public health problem, if we did as is, the current treatment strategy, it would cost us more than 19 million US dollars. And it would still mean that even after the 20 years, we'd still continue treating. However, if we move to the optimized strategy where we have twice a year treatment in the higher prevalence and reduce the proportion never treated, then it will take us 16 years and we will spend $7.1 million. And that meant 63% lower in cost. And secondly, for the breaking transmission strategy, it would still be high in the current blanket treatment. However, moving to precision treatment, where we focus on treating twice a year in the higher prevalence settings, it would cost us less, but also would be able to achieve the target in less than 20 years, 16 years to be precise. However, we know that we have a change in funding landscape, and this graphic that you can see on the screen is work that has been done by my colleague, Dr. Hoya, and it focuses on the funding donations. And you can see in 2025, we've gone down from 126 billion to 54 billion Kenya shillings. And this means that there's a change in funding landscape. And I saw this document that was released last month, and it's called America First Global Health Strategy. And one of the things that stands out, which I've highlighted, is that they say that for there to be a successful foreign assistance program, the program does not only need to look at how to deliver the concrete results, but it should also ensure that it's integrated into our country's healthcare system over time, so that we don't have siloed programs which are not embedded into the healthcare system. And so the next steps of this work, we wanted to look at how would it look like if we integrated the mass drug administration campaigns into the healthcare system, because currently they just do a campaign where over a week they say that they're going to treat both children and adults through the community health care program. But then looking at it, what if we embedded it into the current healthcare program, where the healthcare community health promoters go to visit households once every 6 weeks. And we've seen this now through some preliminary results. And what you can see in the x-axis is time in years, and on the y-axis is prevalence on the top and heavy intensity on the bottom. And we can see that if we incorporated the routine mass drug administration, where the community health promoters treat the households within the first visit they do in the households, and then follow up the people who've not been reached during the next visit, so that we have an additional 20% being treated, then it shows that actually with the routine mass drug administration program focusing through the community health program, then it shows that it's able to accelerate elimination. And even when you go to a high prevalence setting where we only ran the results for 20 years and we simulated 20 years and stopped, we saw that even with the blue line, actually the community health program would actually accelerate the reduction in the infection over time. And the next steps of this work, which is very preliminary, is to be able to run the analysis both in the high and lower treatment settings, and also look at the economic costs of the program as a campaign compared to a routine program into the healthcare system. And I'll finish it off by acknowledging all the different people who've been part of this work, because it's been more of an concerted effort. So thank you, and back to you, Annie.
Thank you, Dr. Motono, for sharing that comprehensive example, showing how data-driven models can help optimize intervention strategies and improve resource allocation in disease control efforts. I think both presentations highlight how modeling can guide real-world interventions and policy decisions. Now we transition to the Q&A session. Post your questions in the chat or unmute to ask. But we already have some directed to Dr. Peter Macharia, and I'll dive right into the first one, which was a question on, are there methods that can be used to integrate different data sources? For example, routine surveillance and cross-sectional to generate these kinds of maps. Peter, did you get the first question?
Yes, I was waiting to be unmuted. Thank you. Thank you, Alice, for that question. Alice was my colleague back at Cambridge. I think right now there are a number of groups that are trying to find ways to combine routine data and survey data. These two data sets in themselves are very different and they have very different characteristics. But if we found a way to leverage their good sides and combine them, that would be like the best scenario. And how these groups are trying is, for example, use one data as a covariate of the other. So for example, you can model using routine data, you get your surface showing how risk spreads across space, then use that surface as a covariate in the model that is using survey data. Now that's one option, and I've seen a number of examples. For example, I think in Rwanda, they did that when mapping malaria for children under 5. The other way is if we can find a way to do the modeling jointly, but I think it would be a bit more complicated. But one can be a covariate of the other, whether survey data becomes a covariate in the routine data or vice versa. I think that's one option that people are trying to explore, and I'm doing the same, but for other health outcomes, not specifically malaria prevalence, because in global health, we have a lot of data from the survey side and from the routine side. If we can find a geostatistical model that is robust and combines the two, much better.
Okay, the other question directed to Dr. Motono. Overcrowding of worms reduced eggs production. What is your reflection about the test sensitivity and egg excretion impact on the model?
Thank you for that question, John Bosco. And yes, there has not been good sensitivity of the current diagnostic tool that's used for schistosomiasis. That has been the CATOCAT. And that's what we have used actually in the model. But I know there is actually advanced work on the CCA diagnostic sensitivity, and we are able to actually incorporate that into the model and just look at the comparison of the two tests, how each of them performs in terms of the looking at the number of worms based on the after treatment. And the second question, and the first question on overcrowding, we use a distribution to be able to account for overcrowding, but we use an exponential distribution such that we don't end up having an infinite number of worms in the body, so that we control for that.
Okay, the other one to Dr. Peter Macharia. MBG involves combining data from different sources. How do we integrate data sources collected at different time points? For example, cross-sectional versus routine. Dr. Peter? Okay.
Sorry, it's the muting issue. So I think that question is linked to what Alice had asked about combining data from different sources. But on the next part, you can do either a spatial model or you can do a spatial temporal model. And a spatial temporal model allows you to put data that has missingness in space and in time also. So if you have missing ears, depending on the characteristics of your data. And I think that's the beauty of these geostatistical models, that they are able to fill in the gaps in time and the gaps in space by using the existing data and the covariates. And then you can do that survey data independently and routine data independently, or you can have a model where one is a covariate of the other, whether spatial or temporal. But as you move from spatial to temporal, the complexity increases and the number of assumptions that you need to make.
And maybe you can combine that with, is there a way to account for recent migration patterns in cases where data is not collected on a regular basis?
Yeah, so I think now with the big data, especially say data from mobile records, so one can see the movement, for example, of people who go and spend, say, a whole week in a place before they come to the routine places of residences. I think with such data, we are able to add that covariate or in whatever manner we think it's affecting the transmission dynamics in our model. I think the big challenge has been more of getting migration or mobility data, but big data is in a way trying to fill that gap. And I think years to come, we are going to see increasingly now mobility or migration data being part of the modeling framework compared to maybe like the past decade.
Okay. And to Dr. Mutono, what strategies do you employ to reduce the population proportion never treated with MDA for schistosomiasis? Do the cost estimates in your model reflect the additional costs of the community health program and the tracking down of the never treated?
Yes, thank you for those two questions. So one on the costs that we have estimated, we unfortunately have not included the costs of actually tracking the proportions never treated. And that's future work that we need to do so that we get the actual costs and explicitly show that if you were actually accelerating towards elimination by involving the population never treated, then maybe it would actually cost you more or less, because for now we don't have those costs. Then the second bit of how you track down the population never treated. And so the one, it would be understanding why they're not adhering to treatment. It might be treatment fatigue, because some of these populations have been treated for a really long time, or just second, with the migration of populations. So that would need a social science study to get this reasons why. And then secondly, it would also be through the community health promoters program, because we currently just use the campaign where people who live in those endemic areas are treated, population 5 years and above. And maybe during that 1 week when they're doing the campaigns, someone is not available. So if we moved to now the routine program where, sorry, I just realized my video was not on. Sorry. So if we move to the routine program where not only just treating during this 1 week, but following up these populations during the next visits to capture these people who are never treated. So we hypothesize that that will also help in reducing the population never treated.
And maybe you can also answer, for your ABM model for schisto, does it mean that you have included different forms of infection for the different age groups given the known higher prevalence in SAC? And what would be the recommendation for intervention below 2% as MDA are halted at this level? Oh, you've already answered. Yeah.
Yes, but I can just briefly mention it. Yes.
All right.
Yes, I can briefly just mention it. Yes, we've included different forms of infection for the different age groups based on the initial graph figure that I had shown, where the 5 to 14 years are generally the highest in terms of force of infection. And then when it comes to the population less than 2%, there needs to be a bit more work that is actually focused on that, where one, we look at the simulations. What if we stopped the treatment and then continue now doing the simulations post now the treatment for a couple of years to look at, do we risk the point of having recrudescence? And also secondly, with the different sensitivity of the diagnostic tools, to look at if we actually employed different sensitivity, do we end up in all of them not risking the recrudescence, so that we can confidently say that if we stopped treatment at 2% threshold, then we are not risking having their infections back after a period.
We have a couple of hands up. Teresa Odero, could you go ahead, please, with your question? And state who you're directing it to. Teresa or anyone else whose hand is up.
Hello?
Hi.
Hello?
Hello,
Are
we
you
can hear
hearing me?
Yes. Yes, Odero.
Okay. Yes. Dr. Odero. I happen to have worked in a project that was dealing with schistosomiasis quite some time back. And one of the main areas they had to put a lot of effort on was health education among school children, and how they would practice the health education messages that they have received. In your presentation, I did not hear much about health education in this field. Is there any need for this? And do you have information relating to that? Thank you.
Thank you, Teresa, for the question. And yes, I agree that there is a lot of work being done around the behavior change communication. And also recently, the Ministry of Health in Kenya has actually developed the behavior change communication guidelines to just strengthen this area. Unfortunately, the models that I have shown here, we do not include the intervention of behavior change communication. And this is because we don't have parameters to be able to show us that if we did behavior change communication, this is the significant impact of that. But we hope that as now this is being done more and more, we will be able to, over time, see the impact of the behavior change communication, and it will be easy for us to embed that in the model. Because as also has been mentioned by Peter Macharia, the models are as good as the data. So hoping we can get more data to support this. Thank you.
Thank you.
Okay. We have another general question, or questions that are combined actually, for Dr. Mutono and Peter Macharia. Would you have information on what test was done to determine the country prevalence of RDTs, EBS, RDT, and based on Dr. Macharia's observation of low sensitivity, what steps will the ministry put in place to address RDT challenge? Dr. Macharia, what strategies would you advise strengthening Dr. Mutono, what strategies would you advise strengthening the schistosomiasis control efforts?
If I got right on the question of RDTs, the question is how to deal with the low sensitivity.
What would determine the country prevalence of RDTs?
Because RDT, they are used to test whether you have the parasite or not. So you can use an RDT or a microscopy. And RDTs are used because they are quick, easy, compared if you are to do a proper microscopy. So these are more widely available within countries, I would imagine, compared to microscopy. And if we had data from microscopy, I think that would be the better one to use for modeling. But I think it's not all the case that you'll be able to get these kind of data sets. And I hope I answered the question the person was asking.
And what steps will the ministry put in place to address RDT challenge? I think they're asking what measures would be put in place to address the challenge.
I think maybe it's not for the ministry, because the ministry has an option of RDT or microscopy, and they would deploy one based on the kind of how the environment looks like and the setup and the transmission dynamics, and also based on the kind of money and resources they have. So I think if the sensitivity is low, is the people who are more used in the production of these tools for testing, maybe it's more on their side to improve, I would think, or give us alternatives or other tools for testing.
Okay. Matana, you want to take yours? What strategies would you advise strengthening the schistosomiasis control efforts?
So the first, it would be on having precision treatment, where we actually target and have the right interventions for different areas based on the epidemiological profile. And secondly, if we can have also more research being done around the different diagnostic tools, and also development of better, more sensitive diagnostic tools, so that as countries move towards from control to elimination, then they have the right diagnostic tools to support this.
Okay, and the other one, to both of you, what kind of modeling tools are usually considered best in an area where prevalence or incidence of an infectious disease is unknown? To you, Motono and Macharia.
So, as I earlier said, the models are as good as data. So if the infectious, let's say the prevalence is unknown, then it would be nice to also now start off from literature to just see, based on the different prevalence that are found in different areas, if that can guide you. But also the connection now, especially from the model-based geostatistics, which Peter Macharia has talked about, and he's able to talk more on this, how now they're able to provide the prevalence at a lower level, and then now the output of that becomes the input for the epidemiological models.
Yeah, it's a complex question, given that if you really don't know what the prevalence or incidence of a place is, where do you start? But if I go back to the very fundamentals, I would think maybe we need to do a survey. We need to do either based on literature, if we can find something connected to those settings, or start with some kind of a baseline survey, because it's very hard to do something in an area if you are very blind about the incidence or prevalence in that area. I think that would be my take if I have such a setup.
Okay, thank you so much for the very many questions, but we don't have so much time left, and please feel free to reach to us via our social media or the email address. And if you have any pressing questions, we'll ensure that they are answered. But thank you so much for your engagement. Yeah. So thank you so much, Dr. Motono and Peter Macharia, for the insightful presentations. And now I want to, before we end the session, I want to invite Asatu again to give our closing remarks, and then I will go ahead and end the session.
Thank you, Annie. So I would like to thank everyone for joining today, these important sessions. And I would like also to extend my sincere gratitude to our speakers today for their insightful presentation, and as well to CEMA for co-hosting this very important webinar. So today's conversation reminded us that modeling is more than just data. It's a tool to guide smarter evidence-based decisions that can accelerate progress toward disease elimination. So I really encourage everyone, especially our Injaz Fellows, to reflect on how these lessons can be applied in your own work and context. So thanks again for joining, for your engagement and participation. Over to you, Annie.
Thank you so much, Asatu. Thank you, CEMA. Thank you, Glide, Injaz, and to our speakers and participants for their thoughtful contributions. This seminar has underscored how data and modeling are no longer optional tools. They are fundamental to shaping effective disease elimination strategies. And we hope this session has deepened your understanding on how data and modeling can accelerate progress towards the global elimination of diseases such as malaria and neglected tropical diseases like schistosomiasis, and inspired continued collaboration across sectors. Thank you once again, and we look forward to seeing you in our next session. Thank you. Bye, everyone.
Thank you, Annie. Bye-bye.